All right, hi everyone. So we're here. This is the last lecture video, and unless something comes up that I can't foresee right now, this is actually the last video that I am recording for this class. So again, sorry about that glare. Using the blue light glasses to try and offset some headaches. So, I mean, I guess it's a good thing that I've never needed glasses. That part's nice, but bad thing is I can't just plug in blue light blocking into my lenses or something. So, before we crack into the final chapter, just a quick talk about your final exam. So, remember that it's on the 28th. And like I said, it will be available from, I believe I've said 9 until 9, so 12 hours. So because there's 15 chapters, it's cumulative, right? Which does mean that anything goes, anything from the textbook, any of the 15 chapters in the textbook can all be on your exam. There definitely will be a greater emphasis on chapters 8 to 15 because you haven't been tested on those yet. However, I don't have any set number, it's going to be 75% the new stuff, 25% the old stuff, or anything like that. So just be ready for possibly anything. A really good way to go about it is to go back and review the quizzes, review your midterm. So you can get a sense of the questions, maybe see what you got wrong. These are things I honestly never did in undergrad, and as a GA and now as an instructor, it's something I really recommend because maybe there was things that you just misread the question, but maybe there was things that you were stuck between those last two answers. So it's like, why did you choose the wrong one, or why did you choose the right one? So it's a really good way to study, is to go back through the exams that you have. So what's going to happen is it's multiple choice, like I said. Because there's 15 chapters, I'm going to make it 150 questions. I think I previously said around 120, but just because of how many chapters there are, we'll have about 150 questions. And I'm going to have it so that once you start it, you'll have about 5 hours to do it. So that means it's available for the 12 hours, but to have a bit more of a valid test experience, so you're not for 12 hours doing a few questions and walking away or looking things up, to try and have some actual validity, because I can't control whether you have your book open or not, really. So to try and keep some of the validity of the testing experience, once you start, you'll have 5 hours to do it. And that'll cover anyone who has any accommodations for extra time, because that equals out to at least 2 minutes per question, because that'll cover, and that'll give a lot of time for people to take breaks if they need to, to stop and pause. And that'll give a bit of a rolling start, because not everyone's going to start it at the exact same time. So, between 9 and 9 p.m., I guess, too, if you want to start it right at 9 p.m., that wouldn't work. But between those 12 hours, people will start it in chunks. So you will, just like the midterm, they will appear one at a time, like one question at a time. But of course, you can go back and forth. So if you want to skip question 5 because you're not sure, you can definitely come back to it. And it isn't forced completion, just in case all of a sudden your computer freezes and now you can't get back in. So it won't be forced completion. So once you open it, you can close it. If your computer's acting funky, that's okay. You can go in and out, just within that 5-hour window from when you started it. And the questions will be randomized. So if you are sitting beside someone doing the exam, because it's one at a time, you may not be seeing the exact same question, and the answers may be scrambled, so just try and keep it a little authentic. But otherwise, because the beauty of it being multiple choice and being within Blackboard, you'll be able to see your score immediately. And once the 9 p.m. deadline passes and the exam disappears, the answer key will be released, or the whole thing will be released. So that's that. Let me know if you have any questions or concerns or anything, but keep in mind that we were told to block off the exam period, and you've had this date for quite a while, so there shouldn't be any issues there with people not being available. So like I said, it will be available for the 12 hours in total, but once you start, you have 5 hours to do it. Otherwise, by this point, you may have done everything else. Possibly you still have quiz 15 to do, but at this point, your second Healthy Change Journal has been submitted, so good job. I plan to have the GAs get back to me within a couple weeks so I can just make sure all the averages are comparable, so everything's fair across the board. And then we will release those back to you. So when that happens, I'll let you guys know, and it'll be the same procedure as before. Reach out to the GA that marked your paper, etc. But that's done, so there's nothing left except for the final exam. For those of you that collected bonus points, I've said this before, but just to reiterate, what happens is for the participant pool, I have a chart from the first half of the course, from the May-June part, for everyone who collected points during that time, and then remember the pool closed and reopened. So then, I haven't yet, as of the time of this recording, but I'm sure I will soon, I'll receive another chart of any points gathered between July and August. And then obviously I'll combine those. So if you only collected 1 point in the first half, but then a second point in this half, or you got all of yours in one of the halves. And those of you that submitted the paper for the alternative assignment, I've got those as well. So what I'm going to do is just make one overall bonus point column and just like combine it all. So when that's released, I'll let you know and just check and make sure that you, if you know you collected 2 points, make sure you get your 2 points. And just a reminder, it was a maximum of 2. So if you did say 4 bonus points worth of studies, I'm sure the researchers thank you, because that's our data that gets us our degrees. So you did a good thing, and you only get a maximum of 2 points. So it tops off at 2. All right, so that's really all I have to say about other stuff thus far. And now on to the last chapter. So this chapter is basically just what to do with Health Psych 101, like where's Health Psych going kind of thing. What more do we still have to do? Hint, there's still a long way to go. I'm sure there always will be. And how does one become a health psychologist? Hint, a lot of school. So to jump right into chapter 15 and wrap it all up, remember a primary area of health psych is health promotion. So among health promotion, a primary goal is to promote health behaviors that can prevent a lot of diseases, especially the chronic illnesses that can't be cured, and put a lot of strain on all aspects of the human systems. Knowing this, a primary area of focus is on those who are at risk for many disorders. So you want to spend more time on the people that are most likely to develop an illness, instead of spending all our time on people that we don't think will develop the illness. So individuals who are at greater risk for particular disorders need to learn to cope with their risk status, because for some people that can be pretty hard, accept that they're at a greater risk, and identify the areas that make them at a greater risk. Did they just get the luck of the draw with genetics, or is it because of some lifestyle factors that can be adjusted? And anything that can be adjusted, they should, to the best of their ability, attempt to do so to reduce their risk and possibly prevent themselves from getting whatever illness they're at risk for. So for example, if you have some genetic risk factors and some lifestyle risk factors, you can't do anything about the genetics, unfortunately, but you can modify the lifestyle factors. So studying people who are at risk is a huge area of research in health psych to help identify factors that promote and increase the risk of developing a particular disorder. So people need to know that certain things are risk factors if they're going to recognize that they should probably adjust them. For example, studying the impact of diet on the development of type 2 diabetes. If someone doesn't know that these things make them at a greater risk of developing type 2 diabetes, they're not even going to have the opportunity to make an informed decision to change their diet or not. Not everyone's at risk for a disorder will develop it, and people who aren't at risk may develop it. Like, it's never that clean and easy. So keeping an eye on those who are at risk that do develop a disorder versus that don't can help identify more risk factors, because it's like, what's different between these people? And then we can isolate those differences and see if there are more risk factors that we haven't accounted for. Because remember, a lot of the risk factors that we know don't actually account for a lot of existing cases of chronic disorders. So there's still a lot more out there to be discovered. And again, a key area is preventing the health compromising behaviors to stop the development of disorders before they begin, and stop them from worsening once they've begun. So remember that adolescence is a major window of vulnerability. It's where the responsibilities put on the person, like from their caregivers, to take care of these health behaviors, but it's not a habit for them to do it themselves, and there's other things much more interesting. So we have that dip in our health behaviors, and it's where a lot of health compromising behaviors first become presented to the adolescent, like alcohol, drugs, smoking. So it's a huge window of vulnerability. So targeting it is probably one of the main areas of importance for health promotion and prevention. So among preventing poor health habits, we have behavioral immunization, which are programs focused on major health compromising areas like smoking, drug use, alcohol, etc. Diet as well, and eating disorders as well. So for example, programs that expose 5th and 6th graders to anti-smoking and anti-drug material have some success in keeping adolescents from undertaking these habits later on. So like how an actual immunization can prevent bacteria or viral illness, these behavioral immunizations are attempting to prevent a behavior from developing. Now, the parents and caregivers are still paramount at helping to prevent these behaviors. So caregivers should be taught how to reduce risks of accidents at home, especially for toddlers, babies. We know that's the primary cause of death, along with SIDS. Instill good safety habits in automobiles, so put on your seatbelt, don't jump around, modeling non-distracted driving, so no texting, etc. And just overall instilling good health habits in children, like a moderate or eating things in moderation, so an overall healthy diet, exercise, keeping up good hygiene, etc. So a lot of prevention goes to the parents and caregivers to model and encourage these behaviors. Now, another at-risk population is on the other end of the age spectrum of older adults. And this is due to, the natural physical cognitive decline that comes with aging, and the natural increase in risk for a lot of disorders, both acute but a lot of chronic as well. Now, the population of older adults is increasing, worldwide, and especially in westernized countries, because of the baby boomers are aging, right? And in the next decade, we'll have the largest cohort of older adults in history that we've ever had. So a lot of people that could be having chronic health conditions and at risk for many conditions. So we need to focus on preserving their health to ensure that as aging occurs, as it's going to no matter what, the health and quality of life is sustained. Because especially as the life expectancy has increased, just because they're living doesn't mean they're living well or comfortably or enjoyably. Working with older adults to preserve health should really emphasize that they still have control over some aspects, which may vary depending on the person. So what do they have control over, or what can they advocate for changes in, like diet, exercise, controlling their alcohol consumption, and other health habits like engaging in regular medical checkups and those screening procedures, like encouraging women or any individual with breasts to get mammograms. In health psychology, there's a need to reshift and refocus our promotion efforts to morbidity from mortality. So recall that the major causes of death have shifted from acute to chronic, meaning people will live with potentially fatal illnesses for some time. So people might know what's going to kill them for a long time before it actually does. One obvious reason for this shift to morbidity and quality of life over mortality is the economic cost of chronic illnesses. So they're expensive to treat because they may persist for years, even decades. They impact someone's ability to work, so then the value they bring to the workforce and the money that comes out of that. For example, people may live with heart disease for years and then require extensive medical attention. But then, money aside, focusing on morbidity helps preserve quality of life, so even possibly enhancing it. What's the value in living longer if you spend much of it unable to do any of the things that you enjoy? Focusing on morbidity may help maximize those enjoyable years an individual has, whether or not they have a chronic illness. So for the future, priorities include addressing more than one behavioral risk factor at a time, because risk factors often cluster. So, think poor diet, low exercise, often come together. And trying to target one, you might end up playing a bit of a game of whack-a-mole. You try and get the diet under control, and then you're like, okay, they need to exercise more. And then when they're focusing on exercising, their diet might get out of control again. Even if you get one well, the other may still enhance someone's risk. So if we can focus on more than one factor at a time, you're getting more bang for your buck, really. Also, maintenance of behavior change. So like relapse prevention, maintaining good behaviors, like sticking to a healthy diet, not doing 1 month challenges and then not working out again, like maintaining that exercise level. Integrating individual level interventions into the broader health policies. So it's great if you can help one person, and for systemic improvement and any systemic change in healthcare, you want it to come from the individual level up to the broader level, so more than one person at a time is benefiting. Specifically, it's more effective if we make it commonplace, right? So integrate these health promoting behaviors and just make them how we live, just a general part of life. So another major factor is not just identifying the problems, but promoting the positive, and not only just highlighting where we can improve, because we're always quicker to criticize than we are to compliment. And the truth is, identifying the things that you're doing well, sometimes people don't even realize what they're doing well. So it can go a long way to identifying that they have control, that they are capable of making a change. Among the positive factors, what big one is our resilience. So people are incredibly resilient, even at times that we don't think that we are. So, for example, if you look at all the things going on around us right now, like the racism, the protests, the explosion that just happened yesterday, the coronavirus, like there's a lot of really hard things going on right now. And yet if you look, you can see a lot of beautiful, kind things that people are managing to do. Like the people that were making masks from home or dropping off care packages for other people. My colleagues, one of my good friends came up with this idea to create a free single session therapy service for Windsor, Essex, which myself and a few of my colleagues were able to be a part of. So when you look, you can actually see a lot of resilient, beautiful things coming about despite all the trauma and negativity. So because so much of our ability to change hinders on the belief that we have control and we're capable of changing, promoting resilience and showing what we've already done and what we're capable of is a huge aspect for health psychology. Promoting resilience includes focusing on positive factors that reduce morbidity and delay mortality. So for example, having positive relationships, like romantic partners, can add years to a person's life expectancy. So interventions to help enhance people's abilities to attract healthy, positive relationships and sustain those relationships is really helpful for preserving quality of life. Additionally, studying resilience includes studying how people spontaneously reduce stress. So when people are able to just be like, okay, enough, how were they able to do that? That's great. How are they able to do that? How do we make more of that? How they seek out self-care opportunities for some rest, relaxation, renewal. For example, personal resources like optimism sense of control, self-efficacy, these are found to be protective against a lot of the risk factors and a lot of illness. So can we teach these? Can we teach people to be optimistic and have self-efficacy? And thus far, there is evidence to suggest that it can happen. So then, not just focusing on teaching people to change the negative, but focusing people to increase the positive that already exists. But unfortunately, individual change on its own isn't enough. Individual change and societal change has to work together to optimize health. It's not really effective if you're trying to make all these changes on your own, but the way society is shaped undermines all those changes. Any effort to reduce morbidity and mortality and to enhance quality of life needs to address large socioeconomic disparities in health and healthcare. So for a lot of people, their individual attempts are just squashed by the way society is set up. So there are a lot of risk factors for poor healthcare that are tied to low SES. And a lot of them you can see on slide number 8. So alcohol consumption, tobacco use, obesity, fewer psychosocial resources, higher rates of chronic illness, low birth weight babies, infant mortality, higher risk of accidents, racial and ethnic differences in health. SES and ethnic differences together impact the delivery of medical treatment. So whether people take you seriously, how quickly they respond to you. And gender, women are not included as research subjects in a lot of disease studies. So even in what we know, if there is possibly a sex difference, we may not know because we're not representing all the sexes in a lot of our populations and a lot of the genders. So really, healthcare isn't fair and it isn't available in an equitable way to everyone. So many of these risk factors also show up in childhood. So making it imperative that health promotion is available for all individuals with a special focus on SES demographics and how it can be accessible to them. So if we're going to have all these incredible treatments, people need to be able to have healthcare, and it needs to be in a way that they can access. So healthcare in areas close to home that don't require a lot of transportation. For people who are working and can't take the time off work, healthcare outside normal business hours. So all these efforts for healthcare need to be able to be flexible to address as many people as possible. Again, recall the information on stress and how stress adversely impacts health. So there's so much evidence, but at the same time, we don't know all there is to know. A lot of the existing opportunities for stress research is among the neurophysiology of stress. So the interaction of the neurologic processes in stress, like the nerve system, the brain. For example, how stress is related to corticosteroid functioning, differences in the sympathetic nervous system activity, things like that. So future studies in this area can help elucidate the pathways by which stress exerts adverse effects on health. And this information can be used to develop more sophisticated interventions involving biological pathways. Within the studies of stress, ample evidence demonstrates that social support can serve as a buffer from stress. So if we think back to previous chapters, this issue is of prominent importance because at this time, divorce rates rise. More people get divorced than stay married. And less people are getting married in the first place. And a lot of people are spending increasingly more time alone. So it's not just that people are choosing like kind of common law over getting married, but a lot more people are choosing an independent lifestyle, which is not wrong, and can be absolutely perfectly healthy. And there's concerns of increased isolation. So if someone's going to be single for prolonged periods of time, that's fine, but just making sure that they still have good social support around them. Fostering social support systems can help to reduce social isolation, promote benefits of social ties, alleviate factors that promote toxic social ties, which are unhelpful at buffering stress, and ensure people get the help they need, like decreasing delay behavior if someone is around looking out for you. Now, Unfortunately, there's a lot of issues in the healthcare system, and it would never be perfect, but we should always be working to change the areas that we know aren't working properly. So most notably, healthcare is very expensive. In Canada, we're much better off than most people in the States because we do have healthcare coverage for a lot of people, but it doesn't cover everything. The system is inequitable with preferential treatment, so especially to white, middle upper class individuals, straight individuals. And many healthcare consumers use services inappropriately. So, to help address these concerns, some of the onus lies on building better consumers or patients. So a lot of it is on the providers and the people developing these programs. And then some of it is on the people who receive. Unfortunately, many people who use health services aren't ill, and many people who are ill don't use health services. So if you think back to people seeking a doctor for like psychological concerns, or when people are having a heart attack and they think they just have a headache or something, so they stay home. Health psychologists are tasked with creating responsible and informed consumers of healthcare. So patients need to be informed about their role in the care, to become co-managers in their own care. So you don't just go to the doctor, especially nowadays, and especially with chronic conditions, and tell them what's wrong and they make it better and that's it. Like, at a bare minimum, you still need to take the medication. They can't come home with you and make sure you take it. So they need to be prepared to partner with the healthcare practitioners, whoever they are, and work with them to deal with their illnesses, not simply receive medication diagnoses and leave the treatment up to the practitioner. Also, working with the practitioner at what optimizes the patient-practitioner relationship. So a lot of those things discussed way back in the first few chapters, like not using a lot of jargon and trying to balance the technical and the emotional quality of care. Additionally, health consumers need to be taught to watch for health issues and behaviors in others, not just with themselves. So this means noticing issues in others and engaging in preventative measures that extend to the general population. So for example, getting vaccinations and wearing masks right now. Again, health services are primarily delivered in methods that are best delivered to people with means, such as affluent individuals, or people who can take time off to go to the doctor, or people who have a car. So it's absolutely imperative that whatever we do with these services, to optimize them, we also need to develop them to accommodate low SES communities, such as universal healthcare programs. In Canada, we're fortunate enough to have things like OHIP, but many still go without healthcare. Many don't have a family doctor, and care may not be accessible, and wait times may be long if it's the only clinic in the area. So there's a lot of special things to consider to make sure, again, it's available for all individuals. So because so much of the focus is on doing these things to improve and preserve quality of life, assessing quality of life is important, so you actually know whether or not you're doing anything. So health psychologists are tasked with developing cost-effective interventions to improve quality of life, especially amongst those with chronic illnesses. And amongst those with chronic illnesses, initial assessment during the acute phase of any illness is a critical first step. Supplementing initial assessment with an assessment of regular needs. So basically thinking outside the immediate illness. You're not just assessing the symptoms, but you're assessing their psychological functioning, their life needs, their social needs. This can help identify, prevent, treat a lot of secondary illnesses that can arise as a result of the primary illness, like depression and anxiety. So remember the importance of recognizing and not just discrediting the role of complementary and alternative medicine. People are increasing their use of CAM at a steady rate, and health psychologists can't ignore the presence of CAM in a lot of people's lives, especially there's a reason that people are using them. So there are needs that these alternative interventions fill. So many CAM interventions alleviate psychological needs, like anxiety that nothing's being done or that of the unknown, and feeling as though they're doing something to take care of their health. So a lot of times just reaching out and engaging in health behaviors helps you feel better because at least you're doing something. So health psychologists can identify the needs filled by CAM interventions and develop evidence-based interventions that can address these needs also. Lastly, recall difficulty addressing death and dying. So it's a pretty tough topic, kind of taboo to talk about, and there's ethical considerations to consider when talking about dying. And yet, everyone dies, so it's a regular natural occurrence of life. As chronic illnesses rise, remember, many people know their death is coming for a long time before it actually does. And topics like assisted suicide, living wills, euthanasia, family-informed care, these are all important topics for health psychologists to study and understand to best approach and possibly implement. So much of the importance on health psychologists is due to the aging population. So how we're about to have the largest older adult population that we've ever had in history. Significant issues arise with the mass of aging persons in the population, and these factors are prominent in the consideration of treatment. So for instance, the elderly are commonly living on a limited budget, like maybe a pension, and may not be able to afford a lot of aspects of treatment. What kinds of economic resources are available to them? What living situations do they have? Do they have someone to help drive them to and from appointments? Do they live in a long-term care home? Do they live on their own? And how do these align and impact any treatment regimen that they're supposed to go on? Additionally, how do their resources impact not only their ability to adhere to treatment, but their ability to even seek healthcare in the first place? Like if they don't drive and they don't know anyone and they don't have the means to call a taxi or take the bus or anything, how are they supposed to seek healthcare in the first place? Can they, do they have the mental capacity to remember to take their medication as prescribed every day? So things like that. Additionally, the use of residential treatment settings like long-term care homes has increased, and there's a lot of considerations in the quality of care and concerns regarding maltreatment. So for example, you may have heard of how a lot of military forces were sent in to aid these long-term care homes, and when they were here, they found a lot of indices of maltreatment. So health psychologists are involved in understanding and developing methods to assess and monitor the quality of care in these settings, and maybe indices of maltreatment that aren't as obvious. Like people sitting in their own filth is pretty obvious, but prolonged isolation is something different that's not nearly as clear. But overall, due to the higher incidence of chronic conditions and the widespread issues from chronic conditions, efforts must focus on prevention, especially among the aging population where there could be a lot of different disorders or health considerations coming into play. An easy example is if you play the what if game and imagine if we had prevented COVID before it hit us. So if they had shut down the borders in February, yes, it would have taken mass amounts of resources on the onset, would have been very expensive, would have hit the economy hard. And a lot of people probably would have raised their eyebrows, rolled their eyes, and thought that this was just ridiculous and dramatic. Yet, on the flip side, now that it's here, now that we're trying to deal with it, prevent a second wave, and treat and deal with what we've got now, it's going to cost a lot more in all definitions of the term cost, like mentally, physically, financially, economically, to treat and eradicate the illness now that it's here. So prevention is always better than, or pretty much always better than trying to treat whatever it is after the fact. So, for example, health psychologists play a large role in advocating for dangers of concussions and sports injuries. And these didn't always exist, and a lot of times people don't know they have a concussion right away. Now, there's a lot of concussion protocols in place for many sports because they recognize the dangers of head injuries, even if the individual feels fine at first, including the impacts of a lot of concussions down the road, so post-concussion syndrome. So health psychologists have a large role to play in identifying risk factors, identifying things that could possibly be addressed or adjusted to prevent an illness or a condition, and then disseminating that information to the public and to the powers that be, like the governmental agencies or the healthcare agencies, to try and make some change. Now, a trend within medicine is known as comprehensive intervention models, which comprise a range of relevant forms of intervention for a patient. A prime example is pain management programs, in which all available treatments for pain are consolidated so that individual regimens can be customized to suit each person and their specific needs. So it's not a one-size-fits-all. A second model is hospice, which you'll recall is palliative care. So the point is to comfort, not to cure. In hospice care, palliative management technologies and psychotherapeutic technologies are available and offered to the patient to address their illness and psychological needs. And a third example is coordinated residential and outpatient rehabilitation programs for coronary heart disease specifically, in which multiple health habits are targeted at once. Like we're going to hit your diet and we're going to hit your exercise at once. Now, this is a relatively novel form of intervention. So most models so far are geared for specific diseases like coronary heart disease, but nonetheless, using this model, we can employ them to address risk factors instead of the actual disease. So for example, they can be developed to attack smoking, alcohol, drug abuse. This is achieved through public health management, including community and societal level interventions, to enhance people's motivation to change and ultimately change any behaviors. Now, if you can imagine trying to basically have a customized intervention program for every risk factor, every illness, for every person, this can easily become very, very expensive. And interventions have to be designed that balance cost effectiveness and treatment effectiveness, because unfortunately it's not an infinite resource, and you want to provide a high quality of care without breaking the bank, because then you're limited as to how many people you can care for. So understandably, a lot of documentation is used to monitor that trade-off between cost effectiveness and treatment effectiveness. For example, we know CBT, cognitive behavioral therapy interventions, work, yet there's a lot of debate about covering psychological treatments in healthcare systems. Like, do they really work well enough that we should cover them, because it's more expensive to cover something under a care plan? And if we're going to cover it, how much? Because people could go to therapy for years. And imagine how expensive it would be to cover like 50, 100 sessions of therapy. Cost containment pressures prompt the development of time-limited interventions. So instead of going to therapy for 3 years, we'll give you 12 sessions, for example. These are generally focused on specific symptoms, so we're not going to work through your whole life trauma. We're going to focus on your depression. They're on time-limited basis, like you have 12 sessions, administered on an outpatient basis. For example, WSIB may offer coverage for a specific amount of sessions, and approval, like it's not that you for sure can't, but you need approval if you want any more sessions. This is effective for some people. I've seen it, I've worked with it, and it does help some people, but it can be limited for generating long-term change and sustaining long-term change. So it's really common, especially among therapy, for people to want to return almost for a tune-up session, or if a traumatic event happens and they want to go back. That's really common. And yet if people do want to return down the road for further sessions, and say their first 12 sessions were covered under some care plan or WSIB or whatever, returning down the road may not be covered. So for generating long-term change and sustaining long-term change, it may not be as applicable or as effective. Overall, cost containment pushes health psychology in the direction of finding ways to keep people out of the healthcare system and to get them out as fast as possible when they come in. And Clinical examples for this can include things like support groups, internet interventions, peer counseling, so to try and help them without getting them into the healthcare system where now we're worried about cost and balancing cost and quality. Now, to document treatment effectiveness, we can literally document symptoms, like measuring symptoms via self-report measures before and after, even during treatment, so even after every session. Further, the evidence of effectiveness of these interventions needs to be presented to the public, because it's useless if the consumers don't know it exists or don't know it's effective or anything like that. And for another example is a lot of interventions may have several components to them. So remember, behavioral interventions, like CBT interventions, there's a lot of different possible components to it. So if there's multiple components, one way to cut costs and to isolate what's effective is to study each component and eliminate any lesser effective components. So an intervention may be studied by measuring the effectiveness of each piece and isolating the ones that produce real change. So I did a workshop on trauma therapy, and there's a part of it where the person writes out the traumatic event, like people have PTSD. And a big part of it is more of a cognitive behavioral approach. And they did do a study and found that the writing piece was less effective than the cognitive behavioral piece, everything else that came into play. So things like that, if you're wanting to find what's most effective, possibly to cut some costs, you can kind of dismantle and analyze each piece. Despite the difficulty between cost and quality, right now health psychology has an awesome opportunity to make significant contributions to medicine and healthcare, and this is through evidence-based medicine. So remember that evidence-based medicine are treatments or evidence-based treatments that have data supporting their efficacy and their safety, and this is gathered using research that follows the scientific method. This is usually done with double-blind randomized controlled trials. So you could get the placebo, you could get the real thing, you don't know, and the researcher doesn't know either. Evidence-based medicine is the primary criterion for medical standards and for approval of treatment regimes. So if it's going to be like FDA approved. Because psychological research generally adheres to the scientific method, there's ample opportunity for the field to offer quality research and guidance. So there's a lot of stigma out there about the legitimacy of psychology, but based on my experiences, I can attest to there's a lot of rigorous scientific standards that we adhere to when we do our research. So overall, a caveat of research, medicine, psychology, etc., is again that bias to white, affluent, westernized cultures. So this is how it is in Canada and America, so this is just how it should be. Why doesn't it work in all these other countries? So unfortunately, North America is a big part of the globe, but it's only part of the globe. Life expectancy is still increasing worldwide in both developing and developed countries, and there's substantial challenges in providing quality care in international health. So health psychologists have a huge role to play here because of the training we receive in a lot of cultural factors, like emphasis on empathy and understanding differing norms across cultures, or just the fact that there may be different norms across cultures. Compared to Western countries, many other countries have a higher rate of acute infections, like the less developed countries, compared to chronic illnesses. And much of this is due to poverty, lack of education, and lack of healthcare resources. So not having vaccines, not having clean water or sterilized environments or healthcare areas or like hospitals or anything. In developing countries, smoking is actually increasing while it is decreasing in developed countries. So this is definitely oversimplifying it. But because North America, like the United States and Canada, developed so long ago, it's like we've been through the smoking and we've come face to face with the negative ramifications of smoking. So now we're trying to get out of that. Whereas as countries start to develop, it's almost like now they have access and now they're experiencing the smoking. Further, as countries become modernized and we recognize and as we in developed countries recognize, like, shit, we need to exercise more. We haven't been exercising very much, and look what it's doing to us. As other countries modernize, they're becoming less active. So as they industrialize and possibly spend less time doing manual labor and more time doing possibly like office work, for example, they're becoming less active. Further, as countries develop and modernize, many are experiencing that shift from acute disorders to chronic illnesses, as we already have, which can be a good thing if it means that people are getting their immunizations, because it protects them from a lot of acute illnesses. And those chronic illnesses, we know, brings increased costs, increased economic strain, increased biopsychosocial impacts. So they're going to be experiencing that, and health psychologists have a huge role to play in helping deal with that. So how do health psychologists help? They're important to understand international health because, like I said, they're uniquely equipped to understand the significance of varying social norms, how social institutions function, and how culturally specific attitudes come into play. So, for example, in some cultures, one person, so in many cultures it's the man of the house, makes the decisions for the family unit. So what they say goes. And this can include whether or not you seek medical attention. So if we say you need to start seeking medical attention and we don't understand why no one is, but we don't take these things into account, we're not going to get anywhere at providing and helping spread our knowledge to the rest of the globe in ways that it can help them. So to wrap up this chapter and the whole textbook is a discussion on how one becomes a health psychologist. So I know a lot of you guys are nurses, so maybe you have an interest in health psychology, you think it's interesting, you just want to learn more about it. Or those of you that are psych majors, if you think this is something you'd be interested in. To be a health psychologist, a person usually goes through the same training route as any psychologist, with differences being like they put a lot of time, energy, and focus into specifically like health psychology avenues versus, just general clinical or like educational psych or organizational psych, things like that. In a nutshell, basically buckle up because you're in school for a long time. And just note that the stuff talked about in the text I'm going to mention is pretty specific to people that know they want to be a health psychologist. So it's a similar route, but you're going to put most of your focus on health psych. So, starting in undergrad, you want to take all the health psychology courses you can, and you want to start to develop a knowledge about biological bases of behavior. So if there's anything you've learned from this text, it's that talking about health psychology got really biological. So talking about all the systems of the body because everything's connected. So you want to know how biology comes into play and how people think, feel, and behave. So courses like neuroscience and biological psychology can help with these. To make you a good candidate for grad school, which you'll need to attend to be a health psychologist, you want to get involved with research assistantships, internship placements, and/or relevant volunteer work to demonstrate that you're committed to the field and that you have experience outside the classroom, so outside of the textbook. Further, you want to get some hands-on field experience, not just to build a good resume for grad school, but also so you see it outside the classroom and you have a better idea of whether this is actually a good fit for you and something you are interested in and enjoy. So for example, working at a hospital or an exercise center, you likely will have some balance, like anyone in general, of clinical and research interests. Like maybe you're half and half. I like both clinical or research. Maybe you hate research and you love clinical work. Or maybe it's the other way around. You hate clinical work and you love research, or you're, somewhere in between there, and that's fine. You're going to have a balance of both, but just know that research will become a part of your life for quite some time, whether you like it or not. I'm like 80% clinical, 20% research, but I still have to do a dissertation and I had to do a thesis, so it's just, you gotta live with it. So that's undergrad. But to be a health psychologist, you need a PhD. You can be like a psychometrist or like a psychotherapist with an MA. Like, you can work in psychology with your MA, but you'll work with a licensed psychologist as a supervisor, which is totally fine. It's just something to be aware of, because only a licensed psychologist, so has a PhD and has passed the licensing exams, can practice psychology without a supervisor. So autonomous practice, so can do private practice and can supervise other people who aren't licensed. So either way, grad school waits. FYI, if anyone ever has questions about how to get into grad school, what to do, specifically for psychology, I can't speak to other programs. So I'm in clinical psych and I have interest in health psych, obviously. So you feel free to reach out to me or any GA. GA stands for graduate assistant. So that means they're grad students. So they've obviously been there. So talk to them, talk to me. 9 times out of 10, we're nice people and we want to help, because no one really tells you how to get into these programs or to do these things. So you just kind of talk to the other students and figure it out on your own. So in grad school, you need to choose a grad program to apply to, likely applying to a few of them. And to choose the ones to apply to, you want to get a sense of your interests. So if you're into health psychology, is there a specific area that you're interested in, etc.? What's your research clinical balance? Do you want a program with a heavier research focus? Do you want like kind of a half and half split, or do you want a heavy clinical focus? This will help you choose that program that best fits you. So you'll apply to those, hopefully get in. And no matter your interests, clinical versus research, there'll be some of both, meaning you'll be taking courses in research methods and statistics. So yes, psychology is a lot of reading, a lot of words, talking about people and behaviors, but like I said, there's a lot of rigorous research, and that means stats. So for example, I took the intro statistics, so I think in Windsor's introduction to quantitative methods or something, and then I took advanced statistics when I was in my undergrad. And then when I got into grad school in Windsor, I took the graduate statistics for the first, the fall and winter term of my first year of my master's. And that was all the mandatory stuff. So there was additional courses in stats available if I wanted them, but they weren't required. So either way, stats are going to be there. And again, you'll want more practical experience, so like placements, practica. And if health psych is your interest, you should aim for the field settings for relevant areas for those practical experience, like field settings in health organizations and hospitals and stuff. Unless you're in a grad program without like a thesis or a dissertation, without like a research component, which is pretty rare in this specific avenue anyway, you'll need to complete a master's thesis for your master's and a PhD dissertation for your PhD, which are big research projects. Once you're done the PhD, you're a doctor of psychology. You are a doctor. You have a PhD. However, like I said, to be able to practice on your own, so to open a private practice or to practice without a supervisor and to supervise other people, you need to be a licensed certified psychologist. So you take and pass the licensure exams. So you work under supervision for a certain amount of time in the area that you want to declare that you're competent in, and then you take these exams. And that's basically saying, you can't declare competency in children if you've never worked with a child before. So you take these exams in the areas that you want them to declare you competent in, and then you pass, and then you're good to go. So when all that long time is done, you can be done with school if you choose to be. However, if you enjoy academia, if you enjoy research, and or you just want further training, like especially if you've been at a school that really specializes in certain areas in health psychology and you want to explore other areas, you can apply for postgraduate work or postdoc. So you apply for a postdoc training opportunity, which takes maybe up to 3 years, 2 or 3 years. And these are undertaken at a laboratory under the guidance of a senior scientist. So it's not mandatory, but for those that are interested, it's a way to get further experience, especially if you think there's an area that you still want a bit more training in. Now, when you're all done with school and you're ready to begin your career, you have several options for employment. So if you like research, if you like teaching, you can go into academia, work at college or university institutions. In the clinical field, you can work in a hospital or in other treatment settings. You can open a private practice or work in a private practice with others. You can consult a workplace or work with governmental agencies. You can also advise healthcare agencies on how to improve their care, such as patient satisfaction. So there's lots of different things you can do with health psych. And it's not like you can only do health psych. You can have broader interests in that. So with that, we are done. So like I said, your marks will be ready in a couple weeks. I'll let you know. Bonus points, once I have all the information, I'll just put it all together and just have one column that you can get up to 2 bonus points. So I'll let you know too when those are done. Your final exam will be available for 12 hours, but once you start, you have 5 hours to do it. It'll be 150 multiple choice questions. It'll look similar to the midterm, one question at a time, but of course you can backtrack. That's just to prevent peering over each other's work if you and your buddy have your computers open at the same time. If anyone has questions, concerns, whatever, please let me know. I did post an announcement on Blackboard that the student teaching evaluations are available. So from right now until the 17th of August, so you'll go through your UWin site to fill those out. I did post a link if you're struggling to figure it out. There's not much I can do to really help you with those because it's supposed to be completely anonymous. I can't even be involved, just in case I was pressuring you guys into giving certain feedback. But please do fill them out. It doesn't take long, but I can't speak for all instructors, but I will say for myself that I do intend on taking that feedback to heart and using it for the future. And if anyone wants to email me specifically, obviously that wouldn't be anonymous, but at this point I have nothing to do with your marking anyway, so I can't, there's no concern about influence there. But if anyone has anything to say, that I'd love to hear from you. It's definitely been very weird teaching for the first time, but not actually ever teaching you guys because I don't even see you virtually. I definitely think it was a good choice to do it this way and not have real-time online lectures because I know a lot of you guys are working during the day and especially in essential services, so I think this made it a lot more accessible for people, and it definitely takes the teaching element out of it because I'm never really interacting with anyone. But in any case, you've been great, and it was lovely virtually hanging out with you guys, and awesome job this year. I look forward to seeing how your papers went and seeing how the final exam goes. So good luck, everyone. Enjoy the last bit of your summer. Stay safe, and please reach out to me if you have questions or anything. But otherwise, take care.